We will be talking about our chapter on safety. We always want to make sure that we are keeping a very safe environment for our resident, as well as a safe environment for us. Healthcare injuries and healthcare workplace violence is a very common thing to happen, and so there are things that we can be doing to help prevent that. So a safe setting is a basic necessity. We have talked about Maslow's hierarchy of needs. We said it starts with our physiological needs, our food, water, shelter, clothing, and then comes safety and security. People have the right to feel safe and secure in the environment where they live. They should not be subject to injuries that aren't necessary and to coming to harm when they're in their home setting. So we want to decrease the risk of infection, of falls, and for other injuries at all times for our residents. Now, one thing to keep in mind is no matter how careful we are, sometimes injuries are still going to happen. We'll be talking a lot about falls today. And we're going to learn about how falls, different things we can do to try to prevent them, but they are still going to happen sometimes. But we want to keep people as safe as we possibly can without limiting their mobility and their independence in any way. So risk factors or accident risk factors, one thing what puts our elderly population at risk is when they do get older, their muscles tend to weaken. Their muscles tend to start atrophying a little bit if they aren't really careful and about building them up. And their sense of coordination and their sense of balance changes as they get older. Another risk factor that's possible is if you have someone who's agitated or has aggressive behavior. So think about your dementia patients when they don't have that cognitive awareness and aren't aware of what's happening around them and they kind of lash out. So awareness of surroundings, confused patients, vision and hearing loss. If they aren't seen properly, they might not be able to see any type of trip hazard or anything that they could run over. Or hearing loss, if they can't hear fire alarms, that they may not be aware that there's some event going on at the facility or in their own home if they're still at home and you're doing home care. They have impaired smell and touch. So they might not realize that something is too hot for them until it's actually burnt their skin. And many people, due to disease processes, due to disabilities, might have impaired mobility. Another thing that causes risk factors is medications. There are drugs that we give people that can cause them to be confused, that can make their sense of balance off. Think about narcotics. Narcotics can make somebody dizzy, can make them confused, can make their sense of balance off when they get up out of bed. So that could put them at being a fall risk. One thing that we want to always do to keep our patients safe is identifying the person. Now, we've talked about this in a past class, but ID bracelets are extremely important. We always want to check the ID bracelet to our assignment sheet to make sure that we have the right person. Don't go off the fact that their name is on the outside of the door and you check their name on the outside door. Maybe somebody got discharged and a new patient came in and they just haven't changed the nameplates on the door yet. Don't just go into a room and say, "Oh, are you Mrs. Jones?" Anybody can say yes to that. I've seen residents who are confused, who go into the wrong room accidentally, crawl into the wrong bed. And then when you ask them, "Are you Mrs. Jones?" they say yes, and they're not. So we always need to get in that habit of checking our ID bracelet to our assignment sheet. And if they don't have an ID bracelet, we ask them first and last name and date of birth. People can respond to any name that you call them. So the other thing you're going to find in a nursing home is if they do not have an ID band, they should have a picture on their medical chart. So on their chart at the nurse's station, if for some reason, again, these residents, they live there. Some of them, this is their home. They don't want to wear identification bracelets all the time. So they will have a picture on the inside of the chart so you can always verify you have the right person. Another thing that we see is, or that we always want to think about for prevention, is preventing burns and poisonings. Now, burns are a leading cause of death for children and elderly. Now, with our elderly, that's more in a home setting than in a nursing home setting, because generally in a nursing home setting, they are not cooking, they're not lighting fires, we don't allow portable heaters in the rooms. So as a general rule, when we talk about elderly, burns being a leading cause of death for the elderly, that's generally more in the home care type of setting. But what we do see in the nursing homes is getting burnt from water temperature being too hot from their bath or their shower. Because again, if their sense of touch is a little bit off, if their sense of touch is not as sensitive as it used to be, they may not realize something is too hot. Now, most of the nursing homes that we go to now do not allow smoking anywhere on the grounds, but if they do allow smoking at the nursing home, there will be a designated area for it, and they need to be supervised. And a lot of the facilities will actually have, it's kind of like a weighted, like a lead apron, a lightweight lead apron that they'll put over the person so that if they drop ashes or drop their cigarette down the front of them, it won't burn them. As far as poisoning goes, we see poisoning happening from household cleaners, from personal care products, from bug sprays. Very common with our young kids to get into things that they shouldn't be into. But our elderly population also, they frequently overdose themselves on prescription drugs. They don't remember that they took their medications earlier. And you're going to find that many of our elderly residents are on multiple medications. And all medications have side effects, and those side effects potentiate with each other when you start adding more of them in there. So there is that potential that they can actually overdose on their prescription medications. And sometimes it can be intentional. They just don't want to live anymore. They're not okay with the disabilities that they have anymore, the way their quality of life is going, and they choose not to want to be alive, so they may poison themselves intentionally. We require in nursing homes and in the home health setting, of course, we always recommend smoke detectors and carbon monoxide detectors as well. Now, choking is something that you had to learn how to take care of choking when you took your CPR class to even get into this. But one thing that's really important that we need to do to prevent choking is make sure, one, we're taking the right tray to the right person. So always check our diet card and check that diet card to their armband. Supervise people who have eating problems, that have dysphagia, that difficulty swallowing. We need to make sure that food is cut up into small bite-sized pieces. And when we're feeding someone, we always want to feed them with a spoon, not a fork. Because if they don't have good upper body strength and they pitch forward while you're trying to go in with that fork, those tines could hit the back of the throat. So we always feed people with a spoon, and usually about a third spoonful at a time. Offer fluids during the meals. So usually after every 2 or 3 bites, think about giving them some fluids. And when we're feeding people, especially if they do have swallowing issues, we want to make sure food isn't pocketing in the mouth. And that's exactly what it sounds like. They just kind of push it over with their tongue, and they kind of look like they have chipmunk cheeks going on. It's hard not to do, but you cannot rush people when you're feeding them. And so I frequently get asked in classes, well, if these people take so long to feed, and some of them do take a long time to feed, and you have to supervise them, and you have 7 or 8 patients, and multiple people need feeding, there are always extra people feeding in the dining room. The restorative nurses aides come in and help feed. The activities people come in and help feed. So you generally have multiple extra people in there helping with the feeding process, because some of these residents do take a really long time to get them to feed. And if you rush them, they won't take as much of their diet as they should. If someone does choke, you guys learned your choking technique when you did your CPR class. So normally the universal sign for choking is grabbing up around your throat, but not everybody knows that. It became the universal sign because most people grab their throat when there's something stuck in it. So with an adult, we do abdominal thrusts. So you make a fist, you go right above the belly button, and you push up and in to get that object out. With children, one and up, we would do the abdominal thrust just like we do with an adult. We just wouldn't go quite as hard. With infants from birth to 1 year, we do a series of 5 back blows and 5 chest thrusts. When a person becomes unconscious, then we're going to modify our technique, and we are going to do CPR. We're actually going to do chest compressions to get the object out. But before we just come up and breathe like you would when you normally do CPR, you would be looking in the mouth to see if there's something there that you could sweep out. Now, one thing to keep in mind with these elderly residents in the nursing home, if they're in a wheelchair, they may not be capable of standing, so you can come around to do your abdominal thrust. So you can come around them while they're sitting in the wheelchair, or you may actually have to drag them down to the floor and modify your abdominal thrusts where you kneel beside them and push up above their stomach in an upward motion that way. The most common thing to cause choking in an adult, For a conscious adult, it's poorly chewed meat, and for an unconscious adult, it's actually the tongue falling over the back of the throat. Another problem, another safety issue to keep in mind that you always want to think about is electrical equipment. So in nursing homes, they can only use approved extension cords. You cannot use a regular home extension cord, but even if they do have an approved extension cord, don't overload your sockets. And anytime if a cord looks frayed, don't use it. Equipment that's brought in from home should always have a ground plug on it, and when people do bring in things from home, we always recommend letting maintenance check it just to make sure it's working okay, that it looks okay. And any equipment that you're using that looks like it's broken in any way, don't use it. Just tag it for maintenance, put it in the maintenance log, and let them come and get it fixed so somebody doesn't get hurt with it. Another safety issue to talk about is our bariatric patients. So we mentioned in an earlier class that bariatrics is caring for the extremely obese person. And so you always want to know what your weight limits are on equipment. So when you're using those sit-to-stand lifts or those Hoyer lifts, or you're getting ready to put someone in a wheelchair, can the equipment support the weight? You may take care of patients that are 400, 500. I've taken care of patients that are 600 pounds. And you need to make sure that the equipment you're using can support their weight. Or here you're using equipment to help you lift, and if that equipment can't hold their weight, it can cause them to fall and get injured. So usually things that are for bariatric patients, it'll be labeled EC for extended capacity, but there are usually always weight limits on your equipment as well. Wheelchair safety we talked about when we talked about our body mechanics and moving patients safely. But when you are transferring a person into a wheelchair, so when you are transferring them from bed to wheelchair or bed to, you're going to put them from the wheelchair room to the activity room or from their wheelchair over to the shower chair, your wheels need to be locked when you're transferring a person in or out of that shower chair. So you need to always make sure you're locking your wheels. The feet should be put on the feet should be on the foot plates of the wheelchair once they're sitting in the chair. They should be removed out of the way when you're trying to actually get them into that chair. And we always push a wheelchair. We don't pull it unless we're going through a doorway. You always want to back through the doorways because those smaller wheels right here, so these smaller wheels right here, if you hit those like metal door jams, sometimes those little wheels can stick and then you'll just pitch your patient forward. So we usually back through doorways. And then remember that once you get your patient up in the wheelchair and you get them situated, then the wheels are unlocked, because if you leave them locked, then it becomes a restraint. As far as stretcher safety goes, you want to have help. Lock your wheels on the stretcher and on the bed when you're moving someone over to a stretcher. It may take 3 people to do this. And I know we keep telling you to stay off the beds because it's a potential infection control issue. But you can, if you have to help move a patient over safely. Sometimes one person does have to get up on the bed and 2 on the other side, and they're kind of pulling them, they're sliding them over while you're helping lift them over onto the stretcher. Keep the side rails up when you're wheeling them somewhere. So once you get them on the stretcher, the side wheels should go up when you're wheeling them around the facility, because that bed is kind of in an up position. That stretcher is going to be in an up position. And we usually move the stretcher feet first. Make sure their arms, their hands, their legs, nothing's dangling off the stretcher when you're pushing them around. Hazardous substances. Anytime you have a chemical in the workplace that could potentially cause harm, if it was swallowed or ingested or inhaled, it has to be labeled as a hazardous material. So there's hazardous communication standards. There's also what we call material safety data sheets. So these will tell you how to prevent issues, how to respond to them if it gets swallowed, if it gets inhaled, if it gets ingested, what you should do about it to keep yourself safe. So they will have these things on all their cleaning supplies, on WD-40, on any potential chemical that they use at a facility. It has to have a material safety data sheet on it. So if you get exposed to it, we can look it up and we can see what's the best first aid care to give you, what's the best way to help you so you don't have any long-term issues with it. Disaster means a catastrophic event. So it can be something like an earthquake, it could be a plane crash, it could be a fire within the facility. And all facilities, all healthcare facilities are required to have a disaster plan. How are we going to keep our residents safe if there was a disaster? Now, there are code systems in the facilities, and we'll be talking about these as we go through the class. But a code triage means disaster, that there's a disaster going on. So generally what will happen is they will call a code triage, and all available staff will actually come to the nurse's station, and then the nurse will delegate what your duties are going to be. They will assign staff and equipment to emergency areas, and they will also try to call in off-duty staff to try to get more help. So you need to know, once you get your job, what your responsibilities are at that agency where you work and what your role is in the disaster. Another potential emergency is a bomb threat. And yes, it happens enough that there's a code system for it. It's called Code Yellow. And if a caller makes a threat, you want to get as much information as you can. Notify a coworker while you're keeping them online. Call the police. You will be asked to look through all rooms for any unusual bags. So we usually do what we call 3 sweeps. So you go and you make rounds and you look low level, you look mid level, you look upper level. Does anything look out of place? Is there some package, some backpack laying there that you're thinking looks off? They don't want you to go and investigate it and open the backpack up. They just want you to, when the bomb squad gets there or the police gets there, you can just say, hey, I saw a backpack laying, at such and such a place. Excuse me. And they'll go check it out for you. Fire safety. For fire to happen, you have to have a spark or a flame, a material to burn, and it needs oxygen. It's usually caused by faulty equipment or wiring, or overloaded electrical circuits, or smoking. So we have to think about those things. We always want to make sure that we're not overloading our circuits, that things that come from a person's home, that maintenance just checks them out, make sure that things have a ground plug on them. Make sure your equipment's working properly. Any material that could easily ignite, you want to get it out of the room. Smoking materials should never be allowed to stay in a room. Residents should never have a light. Even if they don't smoke, they should not keep a lighter in their room or matches in their room. Turn off electrical appliances before you unplug them. Keep electricity away from water. And if there is a fire, you need to know your facility's code. So at most facilities, it is going to be code red. That is the universal code for a fire. But some nursing homes use the term Dr. Firestone because since most people know that code red is a universal code, they do not want their elderly residents to be scared or terrified, especially if they don't have any mobility on their own. They don't want people to panic. So you might hear Dr. Firestone, room so-and-so, Dr. Firestone, and that's their code for a fire. So you always need to know the facility where you're working at, what their code is for a fire. And you should know, where are your fire alarms? Where are your fire extinguishers? And where's your evacuation plan? What's the best way to get out of that facility? You never use elevators during a fire. And we use the acronym RACE. RACE stands for rescue. So any person in immediate danger, you want to rescue them out of the room. So if you go into a patient's room, there's a fire in that room, the first thing you want to do is rescue the patient, get them out of the room. Sound the alarm. So we're going to raise the alarm and follow your emergency procedures. C is contain it, so close the doors to contain the fire. And E is extinguish. Attempt to extinguish the fire if you're trained to do so and you think you can do so safely. The E can also stand for evacuation if necessary. You should always have an evacuation plan. So even for your home life, especially if you have kids, you should know 2 ways how to get out of every room in your house. How can you get out of that room safely? Okay. So if you live upstairs, if your child can't go down the stairs, do they know not to hide under the bed? Do they know to go to the window? Is there a safety ladder that they can get out that window? If not, do they know to, look for the fire department to come? Do you have an outdoor area where you're all going to meet so you know everybody's accounted for? You should always have an evacuation plan for your home as well. And in the nursing homes, they will have them. As far as using a fire extinguisher, they're usually related to ABC extinguishers. Most facilities use ABCs, and your A's are usually your papers, and B is wood, and C, I believe, is for electrical, but your ABCs will cover all types of fires. They also make a K for kitchens, and so in the nursing homes, you'll find K extinguishers, like if they have a large grease fire. So to use a fire extinguisher, you use the acronym PASS. So you pull this pin, so you pull the pin right there. You aim, you take this nozzle and you take it and you aim low to the base of the fire. You squeeze this handle right here and you sweep this nozzle back and forth. So pull the pin, aim low to the base, squeeze the lever, and sweep back and forth. The term patient elopement, it's not a patient running off to get married, but it's when a resident or a patient leaves the facility without telling anyone. And it happens enough that, again, there's a code for it. It's called Code Green. Your dementia patients are at very high risk for this. Now, dementia patients, if you work at a nursing home that only takes care of dementia patients, it may be a locked facility. Only dementia facilities can be locked, where you have to have a key to get in and get out, because so many dementia patients tend to wander. But if you work in a regular nursing home and they have a variety of different patients, they are not allowed to keep those doors locked. So they will usually have these alarm bracelets on, so that when the person goes out the door, if they do not put in the code into the door, once they open up those doors, it will start alarming. So people know that a high-risk wanderer has gone out front. So everybody knows to go look for them and go get them. But patients at high risk have to be identified and monitored, and a plan has to be in place to help find them. If you have someone who does tend to wander and seems to be a Houdini in getting out, they will usually keep that person's information on file with the police department, like a picture of them and their information of them. So if they do manage to wander out and they contact the police already has a lot of the identifying information that they need to start searching for that person. The other thing I want to say about this is, once we get into the clinical setting, this is another thing that I really want to stress upon you. You should know where your residents are. So when we get there in the morning and we give you your patient assignment, and you go get report from the regular CNA, and you check a few things that we're going to be teaching you how to look for in the chart. And then you go to your patient's room, your patient's not there. So where is your patient then? Did you look in the activities room? Did you look in the dining room? You need to find your patient. And if you can't find him, you need to check in with the regular staff. I can't find my patient. Maybe they know, oh, hey, the patient had to go for an appointment, or the patient went to the dialysis unit, or the patient went such and such. But it is not okay. There are many times that I'm going around making rounds with my students, and I'll get to a student, and we got there at 7 in the morning, and now I'm connecting with this student, and it's like 8:30, and I'll say, well, how's your patient? Well, I don't know. I can't find her. That's not okay. How do you know your patient didn't wander off and has been missing for an hour and a half? So we always need to make sure we can find our residents. As far as workplace violence goes, violent acts or threats of violence at work on duty, it's called a Code Gray. And more assaults happen in the healthcare industry than in any other industry. So you have to keep that in mind. People with weapons is usually a Code Silver, especially if you work in a hospital setting. Now, I will say workplace violence is more common in a hospital than in a nursing home, because we get gang members, we get police holds, we get mentally ill patients, we get alcohol and drug abuse patients. They're waiting a long time for their care. You've got upset, agitated family and visitors. Now, it's not that we don't see them in the nursing home as well. We do get mentally ill patients. We can get drug abuse. But as a general rule, you will see more of it in a hospital setting. But always remember, if you have a patient that's getting really agitated and really angry, don't go up to them. Don't go up to them and try to touch them and, oh, everything's going to be okay. Get away from them. Get help. Okay, don't put yourself close to that person. If that person is threatening or showing signs of aggression, you need to get out of that room and get help. Okay, you need to protect yourself. So ways that we can help control and prevent workplace violence is, one, we should be wearing our ID badges. And when people come into the facility, they're supposed to check in, and they usually get in like a little check in that they're a visitor. They don't have that. You just need to say, oh, I'm sorry, you need to go back to the lobby and get checked in. Okay. Use a buddy system when leaving at nighttime. If it's really dark out at night, don't go walking out to the far end of the parking lot on your own. Use a buddy system. Don't wear things around your neck. Long hair should be up in a bun, not a ponytail. Ponytails are really an easy thing for people to grab, and it hurts like no other. And wearing things around your neck. I had a friend who used to wear her stethoscope around her neck. I used to wear my stethoscope around my neck. I thought it looked really cool. And I used to work ICU, CCU with her, and she was bending over a patient, and he grabbed both ends of the stethoscope and started choking her. And she was in there for a little bit before we heard her, realized that there was a problem and could go in and help her. She ended up going out from work on a neck injury, and she never came back. It was the end of her nursing career. So I am going to tell you, you never wear things around your neck. Hair should always be up. It's an infection control issue, and it's a safety issue. And you want to make sure, one of the things we talked about when we were getting patients up out of bed, don't let people grab onto your neck. Don't have people grab onto your shoulder when you're lifting them up, because if they start to fall, your neck is the first thing they're going to grab. So when we're dealing with an agitated person, stand away from the person, stand close to the door, know where to find call lights for help, try to stay calm, be aware of your body language, do not touch the person, tell them you're going to get the nurse to help them, and get out as soon as you can, and report it to security so you can get help. Risk management is a part of the agency where they will evaluate any accidents or safety hazards that might have happened. So let's say a patient falls. You're going to fill out an incident report, and the risk management is going to evaluate it and see, okay, what happened? Is there a process we need to change? Is there something we're doing that we could change to make it better, to make it more efficient? When I first became an RN, brand new RN, I was working on this floor, and we used to give this medication through the IV if a person was having heart arrhythmias. And if the doctor wanted to try stopping the medication, instead of taking it out, we just clamped the tubing. We didn't actually take it out of their IV. We just clamped the tubing on the part that was running in. So if we had to start it back up, we wouldn't have to waste new tubing, get things rehooked back up. Well, I clamped the tubing, and I don't know if the family saw it clamped and thought it was a mistake, or if the patient played with it. I don't know what happened, but the patient, somehow the tubing came unclamped, and the entire bag of medication ran into the patient all at one time. And it's a medication that can cause seizures, can cause hallucinations if it's given in too big of a dose, which she got the whole bag. I was horrified. I mean, you don't go into medicine because you want to hurt someone. And I was sure I had hurt her, and she ended up being fine, fortunately. And I had to fill out an incident report. I was sure I was going to get fired. And you know what? They looked at the process and they said, we taught you to do it this way, but it's a bad process because of this. So the policy got changed at the facility that if you stopped the medication, you had to disconnect the whole tubing. You had to take it out of the room, just so that an accident like that couldn't happen again. So risk management will evaluate accidents and errors in the workplace and workplace violence incidences, and determine if we can change our practices to make things better. The other thing that came out of risk management is a lot of facilities use the color-coded wristbands. And so a yellow band, and hospitals use them a lot, nursing homes, maybe not so much, but a yellow wristband would be for fall risk. And it's a yellow band, and it will actually say fall risk on them, or it'll have a falling star on it. The red band is for allergies, and a purple band is for do not resuscitate. So if they die, you're not supposed to start CPR for them if they die of natural causes. Now, when it comes to personal belongings, we should try to keep their personal belongings safe as well. We try to send anything of value home with the family. We would rather them not keep it at the bedside because we don't want things to, we don't want things to get lost, especially things of value. So jewelry and money, we prefer them to either send it home with the family or to put it in a valuables envelope. So count their money. And if you do put things in a valuables envelope and put it in the facility safe, you're supposed to count the money and the belongings. You put it in the envelope, you list it, it gets sealed, and you sign across the seal and they sign across the seal, or their family does if they're not able to. And then it goes straight to the safe. Otherwise, things that are kept at the bedside, hearing aids, dentures, I mean, we have to be really careful with them, and the containers that they're in should be labeled with their name on it, because we don't want to lose those things. They're very expensive and they're hard to replace. So we will stop there, and